I know that people are still joining, but we want to get started because we have a lot to talk about in this informal conversation today. Welcome, everyone. I'm Marie Abraham, Vice President for Programming and Publications at the Institute for Patient and Family-Centered Care. And today, very excited to say we are joined by 4 experts in this topic of shared access to adult patient portals. So we have Dr. Cait DesRoches, Executive Director of OpenNotes. We have Dr. Timothy Farrell, Professor of Medicine, Division of Geriatrics at the University of Utah School of Medicine, and also Physician Investigator at the VA Salt Lake City Geriatric Research, Education, and Clinical Center. We also have Dr. Jennifer Wolff, the Eugene and Mildred Lipitz Professor at the Department of Health Policy and Management at Johns Hopkins Bloomberg School of Public Health. And we have Rosie Bartel, who is a patient partner at the OpenNotes Lab. And providing technical expert support is our colleague, Matt Da Silva. So today's discussion is shared access to adult patient portals, a vital tool for care partners. And we're really excited to see how many of you have joined today. It's obviously a topic of great interest to you. Please feel free to chat in your name, your organization, and where you're located in the chat. We are recording this conversation because some people only registered for the recording, so we want to be able to share it with others, and we'll be posting it to our website. While we love seeing faces, that's wonderful. If you prefer, you can go off camera during the presentation, but we would encourage you to go on camera when we go into the Q&A. Next slide, Matt. So we really want to acknowledge our PFCC Connect sponsors. Thank you to University Health and Emory Healthcare for your continued support of PFCC Connect. Without you, we really wouldn't be able to be doing this today. Next slide. So as you know, our conversations are intended to be interactive and informative. And the presenters will be sharing slides to set the context and provide information to get the conversation started, and then we'll dive into the discussion portion. We just want to remind everyone of our group agreements. So be as present as possible. When we move into discussion, it would be great if you can go on video. Participate actively. We encourage you to be curious, ask questions, but also share your experiences, perspectives, and any challenges you've faced. You can either chat in your questions or you can raise your hand and we'll call on you. Let's share space, allow others to contribute to the conversation, embrace a learning and growth mindset. All of you bring expertise and we have a lot to learn from each other. And then finally, we hope you enjoy the discussion and have fun. If you do experience any technical issues, you can chat to Matt directly. Next slide. So thanks to all of you who shared some questions and comments when you registered. Here are some of the issues that we learned about what you're most interested in. So who can be designated as a care partner? Family member, friend, caregiver. How can privacy be managed and protected if the patient has concerns about sharing certain information with their care partner? How can patients and their care partners be encouraged to access their portal? And can PFACs and Patient Family Advisory Councils and patient and family advisors be helpful in raising awareness of accessing patient portals? And what strategies can be implemented to enhance sustainable use and usability of patient portals? So with that, I'm going to turn it over to our wonderful experts. Next slide, Matt. And I think we're starting, I don't remember who we're starting with. Is it you, Cait? Yes. Okay. All right. So I'm going to go off camera right now and go for it.
Thank you so much for joining us today. I've been watching the different locations come in the chat. It seems like seems like such a great group. And I want to give a special shout out to Cooley Dickinson in Northampton. That's an area close to my heart. So glad to have you here. I'm going to just get us started very quickly. So if you can go to the next slide. Here's what we're going to cover today. We're going to talk about the background and context. So Jennifer Wolff is going to highlight some of the work that she and I have done together as part of the Coalition for Care Partners, which is an initiative that we founded to focus on digital strategies for care partners of older adults. Then we will turn to Rosie Bartel, who will talk through some of her own personal experiences with having shared access to the portal. Then we're going to hear from Tim Farrell, who is the clinical champion on one of our projects on one of the Coalition for Care Partner projects. And then I'll come back and start thinking about raising a few questions for our discussion. So with that, I'm going to turn it over to Jennifer. I'm not going to introduce all of the speakers. They can sort of introduce themselves as they go. So I'm going to turn it over to Jennifer now.
Thanks, Cait. It's lovely to be here. If you'll turn to the next slide. I think I've already been introduced, so I'll just take it away from here. So I want to read this quote just to kick us off. This quote from Susan McDaniel says, "Without considering the patient in his or her family context, inadvertently eliminates a wider understanding of illness and a broader range of solutions, including family members, means the clinician has enlisted his or her most potent allies." Next slide. There's a growing appreciation of the value that families bring to care delivery, but their presence and the nature of their involvement is not currently captured in a systematic way, and families are too often invisible in systems of care. And so we are talking today about shared portal access, which is an initiative that allows health systems and clinicians to explicitly clarify when family care partners are involved in digital health interactions through the patient portal. So shared portal access, it's an existing functionality that allows patients to register one or more family members or trusted friends who can access their electronic health record such that the family care partner has their own identity credentials. So in answer to one of the questions earlier, the patient can register in many systems multiple care partners, and they are not limited by legal status in terms of being a legal guardian or being a immediate family member. So we know from a range of sources that currently care partners typically use patient credentials, and so shared portal access, or where a pediatric patient has a parent who's involved, is widely recognized, but there's been much less attention to awareness and use of shared portal access in adult populations. And I just want to say one last word, which is that we know that words matter, and I want to note that we are using shared access rather than proxy access to better differentiate the patient portal and registration for the patient portal as separate from legal processes involving impaired capacity. Next slide. So why shared access? There are a number of benefits of extending family care partners their own identity credentials to access the patient's electronic health record. This respects patients' preferences. It facilitates appropriate information access for care partners and access to timely, transparent, accurate information about the patient's health that is important and beneficial when the care partner is involved in coordinating care and helping with co-manage care delivery processes. It also helps clinicians know who is engaged in electronic interactions when it's someone other than the patient. And then I lastly want to say that some patient portals allow patients granular privacy control, so they can decide who sees what information. But this is not widespread. Next slide. So the project that we're talking about today emanates from a collaboration between Johns Hopkins University and OpenNotes, and we are tremendously grateful for support from the John A. Hartford Foundation and the Cambia Health Foundation. We partnered with 3 clinical sites, including University of Utah with Dr. Tim Farrell, who's here today with us, and each of which selected specific service delivery lines that care for older adults. And the overarching objective of the initiative was to increase registration and use of shared portal access, which is an existing functionality, using educational awareness initiatives. It's basically a public awareness campaign, focusing on older adults who are established patients at the 3 sites. Next slide. I just want to acknowledge that this is a busy slide. I'm not going to walk through the entire workflows, but I want to just depict these were co-designed. There was a lot of partnership with these clinical our partner sites. And so we co-designed workflows that were meant to serve as a no wrong door approach to raising awareness and streamlining workflows to increase shared portal access. We co-designed a range of patient-facing materials. These included posters, brochures. We had the institutional websites of the 3 organizations were updated just to support awareness of the registration processes. This initiative was also supported by clinical workflows that increased clinician and staff facility with registration for shared portal access through tip sheets and smart phrases as well as the annual wellness visit instructions. And Dr. Tim Farrell will present some of the branded materials that were developed when he speaks. Next slide. I just want to make a plug for the final paper that was produced as a part of this collaborative initiative, which was published in JAMA Network Open in February of this year. Next slide. And some of the key takeaways that came out, which found that the new registrations for shared portal access did not markedly increase, but among care partners who were registered, there was notably greater use of the patient portal. Also, importantly, patients who newly registered for the portal during the demonstration period were twice as likely to have a care partner registered relative to those who had already been registered, suggesting that education and implementation of shared access registration could be targeted at the time of initial patient registration. We found that care partner use of the portal increased across numerous functions, including logins, viewing of lab results, viewing of clinical notes, but there was no marked increase in care partner secure messaging, which should alleviate concerns about impacts on clinician burden and workflows. We found that shared portal access functionality was greater than patient access for many selected functions relative to patients who logged in. And we found that shared access uptake was much higher in service delivery lines that cared for older adults versus general primary care. With that said, we found that recollection of the initiative was limited and that many care partners continued to report using patient credentials. And I'm going to turn it over to Cait now.
Thanks, Jennifer. That was a very quick summary. We can certainly answer any questions that you have, when we get to the discussion. So part of what the Coalition for Care Partners is doing, in addition to these studies, is we've convened a shared access to the patient portal for older adults learning collaborative. That is a mouthful, and we really just call it the Shared Access Learning Collaborative. And the plan there was to bring together stakeholders so that people could learn from each other, talk about best practices and challenges, and disseminate tools and strategies. We meet quarterly. At the end of the talk today, we'll have more information about how you can join us if you want to. And the Shared Access Learning Collaborative is really made up of health professionals, patients, care partners, vendors, advocates, IT folks, Next slide, please. So one of the things that the Shared Access Learning Collaborative decided to take on was to try to really understand, why is it so hard to get people to sign up for shared access? So we did a secret shopper exercise where we got 24 survey responses from 18 individuals about their experience with trying to either get shared access for a friend or family member, or to share their own portal access with another person. This was done across 17 different portals, including Cerner, Epic, and Athena. And we had 9 that tried to grant access to someone else, and an additional 15 who tried to get access. So when we looked at those survey responses, we saw that 8 attempts were a complete failure. They were never able to get this kind of access, and 14 attempts were successful. But the 5 of these successful attempts took more than 1 day to complete. Some of them took up to 2 weeks to try to complete. So it was not an easy process. And when we asked people to report on the kind of barriers and facilitators, next slide, there were barriers related to technology. So it was difficult to navigate, or they had extra verification steps. There were barriers related to forms. So these are processes that healthcare organizations put in place. They're mostly related to compliance and risk management, but they required hard copies of forms or wet signatures, and then access to information, and to that we include in their kind of privacy concerns, but also just access to a person who knew how to help them was difficult. Next slide. So one of the members of our Shared Access Learning Collaborative, who's been very active in talking about a lot of these issues with us, Rosie Bartel, is going to talk a bit about her own experience with having shared access.
Okay, my name is Rosie Bartel, and in 2009, my life changed forever, and I had a knee replacement that turned into a MRSA infection, and that led to 58 surgeries, over 200 hospitalizations. 15 times I've developed septic shock, and I had 3 amputations. After my 3rd amputation, I went into sepsis and was flighted from my hometown to the teaching hospital that I was going to, which was 2 hours away. And at that time, I ended up in a coma for 6 days. And my family didn't have shared access to my portal. And so basically, they got some information, but they didn't get all of the information. And my husband kept asking for information, and they'd say, well, you don't have access to that information. So I have to tell you that when I came out of that coma, I definitely gave shared access to my husband, even though it was a big process at that point. And that was in 2017. In 2020, my husband, who I also had shared access to his portal, went to the doctor in early March of 2020, and was not diagnosed was misdiagnosed. And several times between March and the end of June, he was misdiagnosed. And finally on June 26th, he had an MRI and was diagnosed with 2 kinds of bone cancer, and it was secondary to something else. And so then we got him into an oncologist right away, and that oncologist was also very good at writing his notes. He wrote the best notes I've ever seen. But anyway, basically he was diagnosed with multi-organ cancer. It was all terminal. It was all less than 6 months, and probably on the short end of 6 months. So we made some decisions, and those decisions were made between my husband and myself and the oncologist. And those notes became our lifeline, and the lifeline for my family, because on July 28th, we lost him. So basically within a month and 2 days, we lost him, but yet the notes that the doctor wrote and the ability for us to share those notes and have access to those notes were critical to our grieving and making sure that we were able to hear and feel and know that we did the right things and we did the things that David wanted. And so, shared access meant a whole lot more than just words on a page or test results. It meant that we felt that we as a family had heard all of things that David wanted and cared about. So basically, I've shared a time when we didn't have shared access, and I hadn't given shared access to my husband to learning about this. But as I was doing this process with the shared access collaboration, I was at one of the cancer centers because I go there every month because of my blood issues. And so I asked them about shared access, and they said, oh, we are definitely promoting this right now because we've had some incidences where patients didn't opt for shared access. And then they had problems when they ended up in the hospital. So they said, we are really promoting this. So, it takes a village to promote shared access. Patients need to share it. Clinicians need to share it. Everybody in the health department, health industry needs to share it. So that's the story. And I hope that this helps you understand why shared access is so important to us.
Thank you, Rosie. Your story is always your story is inspiring, and the stories that we hear like this are part of the reason why this work is really central to what we're doing. Can we go to the next slide? Dr. Farrell, take it away.
Thanks, Dr. DesRoches, and it's great to be here. And I just actually had an opportunity to meet with Rosie yesterday, and I think she so eloquently described sort of, the importance of shared access and stated better than I ever could sort of really, I think, why it is really an age-friendly intervention. And so I'm going to talk a little bit about our experience at University of Utah Health. You can see our age-friendly community care excellence for older adults logo. I'll talk a little bit about what that is and why it's so important to consider shared access as something that can really advance age-friendly care for older people. Next slide, please. So Jennifer, Dr. Wolff alluded earlier to the materials in the clinic, and I wanted to share with you some of what our patients were seeing. So when they walked into the exam room, they would see a poster that kind of looked like this. People remember less than half of what their doctors say. And for each of the 3 health systems, we had the same kind of messaging with the different branding. You can see the University of Utah Health branding at the bottom right, but you can see the sort of accessibility and kind of power, but simplicity of the message that we're trying to get across to patients. That, my chart, in this case, that was the sort of vendor through Epic, but that platform really makes it easy to connect with your physician and access all the information that Rosie talked about earlier. Next slide, please. And just one more example of what we provided to our patients. We gave them this handout that provided some of the same information with a QR code, lots of different ways, telephone or in-person ways to access shared access. And just the information you would need as a patient to sort of get started, because this would be, for some patients, sort of a new thing that they had not experienced before. Next slide, please. So at our clinic called the Madsen Geriatrics Clinic, we have about 3,000 patients. So it's a busy primary care geriatrics office. And I want to tell you a little bit about some of the take-homes for us having participated in this project. The first one is that, despite, being in an academic environment where there's more than one study going on sometimes, as well as the usual clinical demands, we really had lots of enthusiasm. We had a director of our nursing, outpatient nursing, who really took on this as sort of an important part of what she does, because I think our staff immediately saw the value of this, and they were really welcoming sort of a more structured approach to getting more shared access. The human-centered design that Dr. Wolff talked about in that diagram of really making sure that we're trying to make this as easy as possible, and kind of the no wrong door approach also resonated with our clinic. There were some barriers. Probably the biggest one was a little bit out of our locus of control, was that the sort of centralized health information management office in our health system still required a paper signature to sort of authorize the care partner to be able to access the medical records. So that was sort of a barrier. However, I think a facilitator to this in our clinic was that a lot of the discussion with patients and their care partners happened before and after the clinician came in. I mean, I can tell you, as a clinician, sometimes we're not the most reliable in terms of getting people signed up, but having it hardwired with our medical assistants and staff who were already sort of doing this and responsible in large measure for the proxy access or shared access really made it quite seamless. Next slide, please. So I mentioned earlier that, age-friendly care, it's so near and dear to me that's in my job title now. I'm Associate Chief for Age-Friendly Care. But we try to walk the walk with this, as Rosie, I think, would say. And I'd like to just talk about some of the benefits of shared access from an age-friendly perspective. So for those of you who are not familiar with the age-friendly framework, it's an evidence-based approach to, first of all, not cause harm to older people, but also to make sure that older adults are getting evidence-based care according to these M's. Most importantly, the North Star, what matters most to patients, medications, not giving people meds that interfere with what matters most to them in terms of side effects, making sure that we are addressing mentation with delirium, depression, and dementia, and making sure people can move or have good mobility every day to do what matters most to them. So our care is sort of guided by this framework, and shared access, I think, really aligns well because, first of all patients, all older adults, also all younger adults too, and kids, everyone, really to know what matters to them. Secondly, if you have some sort of physical or sensory impairments that make interacting with computers and tablets and smartphones, the internet difficult, shared access can be very useful. If there is polypharmacy, taking 5 or more prescription medications, keeping track of all that is far easier if the care partner is involved. And finally, with the mentation last but not least, older adults with cognitive impairment of varying degrees, this can be incredibly useful as the care partner becomes increasingly involved as the cognitive impairment progresses. So you can see how the forum's framework really nicely, in my view, sort of encapsulates why shared access is an age-friendly approach. Next slide, please. So my last slide here, just to conclude, there are barriers to shared access registration and patient portals that can be challenged and overcome, such as paper registration. But I think the general enthusiasm for this and the fact that it really did not add extra time, it was just sort of a new way of approaching how to do the access was really appreciated by our staff and our patients. And quite well received. And as I mentioned in that previous slide, the alignment with age-friendly forums is just so apparent, especially with the North Star eliciting what matters most to patients and when mentation is impaired. So with that, I will hand it over to our next presenter. Thank you. And I'll be happy to answer any questions at the end.
Thanks, Tim. If we could just go to the next slide, this is our sort of closing questions or things to think about. So one of the things that you saw those barriers, that barrier slide, and you heard Tim and Jennifer talk about some of the barriers, Rosie talking about her experience. So we're really interested in thinking about how to raise more awareness among care partners and patients for shared access. So understanding that this is an option, I think is something many people don't even know that this is an option, let alone why it might be beneficial for them, and then a third step of how to do it. Also raising awareness among clinicians, staff, and of health systems, again, around why shared access is beneficial and how to reduce organizational and kind of technology related barriers. Next slide. So we are happy to answer any questions or just open up for discussion. Marie, do you want to go ahead?
Yes. Oh, thank you so much for that wonderful, like all four of you did an amazing job. It was so informative. I'm so glad you're here. Do people have questions? If not, we have a few questions. I think Cait has a few questions in her back pocket, but do people have questions? If you do, raise your hand, and we'll call on you. Oh, that was a lot of information to take in. Yes, Sherry?
So I'm interested in shared access from a family caregiver perspective. I remember a relative of mine gave me access to their Sloan Kettering Memorial portal. And I didn't know as a caregiver, what was I allowed to do? Can I read questions that they're asking their doctor? Can I read results? So I'm curious, when you're doing this, are you actually thinking about the family caregiver or whoever's being shared with? Are you thinking about that experience, what they can see, what they can do, and how that's communicated to them?
Who wants to take the first pass at that question?
I'd be happy.
Jennifer or Tim?
I'll say I'll be happy to take a first pass just from the perspective of an end user. As a clinician, I can tell you that I regularly exchange my chart messages with the care partners. I hope I'm not using trademark terms that I shouldn't, but and they are generally able to get in and see my notes and see the lab results. So I just want to start with that as a baseline, maybe to have Dr. Wolff build on in terms of what they can see and what we can share.
So thank you for your wonderful question. There is a lot of variability in how patient portals have been implemented across both vendors as well as clinical sites. In general, the person the care partner who is registered has mirror images of the portal functionality that the patient has. The major difference, though, is that it's more clear to the clinician who's logging in, and so it gives that care partner immediate legitimacy as opposed to having to, adding a step of indicating who they are, which not all care partners do. I think as we move to there's been a lot of technological innovation, including the integration of artificial intelligence into some electronic medical record vendors. And so I think one of the issues is the ability to be able to innovate is quite exciting. And that is something that becomes important. The other issue is that increasingly the patient portal is a means of completing legal documentation about the patient care. And so it becomes increasingly problematic from a care delivery system if the information is not reported by the patient. It becomes more important to know who's contributing that information. So I would say that the systems that are in place now are not immediately ready to be able to support caregiving needs, but they could in that through having your own credentials, it's possible to send electronic surveys, for example, for caregivers to report if they, the need for skills or education and training that could be disseminated, through videos or electronic referral resources. So I think it's a quite exciting time. I'm going to stop talking because I know Cait is probably going to have something and Rosie are likely to have things they'd like to share too.
I'll just mention that when we designed the materials, when we co-designed the materials for this project, and we'll have a link to that at the end of our session today, we worked with patients, care partners, marketing and communications people, the IT staff, to make sure that what we were developing was patient focused. So the decision to grant shared access is in the hands of the patient. So all of our materials are focused on here's what, if you grant proxy access, because that's what we were calling it that's what Epic called it at the time that we created these original materials. If you grant proxy access, here are the things that your trusted friend, family member will be able to do. So we didn't specifically target care partners with our materials because we wanted to respect patient autonomy.
And I guess I agree with everything everybody said, because I was part of that team that created that, I was part of the team that was in the collaborative, and I felt that our voices were heard and really well received.
Carrie, I see you on video. Do you want to, and I saw your chat, do you want to ask that question, or do you?
Sure. Yeah, thank you very much. Carrie Gillespie here from Toronto, Canada, and I'm really excited to hear about this portal. And so my question in the chat, and thank you, Dr. Farrell, for answering it as well. I imagine, and Rosie, you mentioned how good the communication was in the notes. It seems like it was really clear. So I wondered, is there a future where we see maybe training for clinicians on how to really put thoughtful, person-centered notes, everyday language summaries together so people on the receiving end can really benefit? Because I imagine there's so much variability and maybe literacy challenges and differences that might get in the way of actually the notes being useful. So any comments related to that?
I have two comments, and then I'll turn to my colleagues and see what they think. We're actually working, have been testing a curriculum for medical students as they learn to write notes. Here are best practices and suggestions for how to write person-centered notes, now that you know that patients can read them. So that's, as far as we know, that's the only effort going on at the moment, but I expect we'll see more. And then there is a technological fix to some of this as well. So we know about sort of ambient scribe companies, for example, that where they are, the ambient scribe listens to the conversation that's happening in the clinical visit. It creates a clinical note for the clinician, but they can also generate patient-friendly summaries that have things like, here are your next steps. Here are the most important things we discussed today, that are organized more in the way that a patient thinks rather than the way that a clinician thinks about writing their notes, which is, they have very structured ways of doing it. So I think this change is happening. The curriculum side is slow. I think the technology side is probably going to move faster.
If I may just add one quick thing, and I think I see Nancy Wexler from the Hartford Foundation, but I just want to give a shout out to the Hartford Foundation, the 4Ms and IHI, because I think the 4Ms offer a very nice way to train the next generation of healthcare professionals. And also we're starting to see even note templates that clinicians use sort of shift a little to become more age-friendly. And so the 4Ms really provide a nice patient-centered way to communicate. So for example, we'll talk about what matters. I could put in the my chart message I respond to a patient with, let's talk a little about your values. What are your goals of care? I mean, those are very non-medical terms that I think can really, if they're asked in an open-ended way, can elicit some discussion. So, and also just to say, yes, we are seeing AI Sometimes the computer will actually type up a whole response that I can review. And I will say it tends to be much more polite and courteous than a lot of physicians, the way physicians typically write notes. So maybe that's an advance in itself.
And during, before the CARES Act made a law that you had to write the notes and they had to be available for patients, we did a lot of work with OpenNotes. I even presented at Epic with 2 physicians and Liz, because, you know, around OpenNotes and how to write notes and things like that. So we did a lot of work with physicians writing notes early on, and some, you know, some took it and some didn't, but yet I feel that a lot more people, you know, took our explanations of why notes were so important to patients and why they needed to be written in a way that patients could understand them. So I felt that we had, you know, we got a lot of buy-in when we presented to physicians. So.
Thank you, Rosie. We have 2 hands up. Mina, do you have a question?
From a fragmented system with a private dominated fragmented system. The system of shared access seems to be extremely important, but in its implementation, can it be done nationwide? Can doctors be made to? Can such regulation be brought that doctors are obliged to provide shared access?
Thank you for the question, Mina. Who wants to tackle that?
Well, I can start, but I would love to hear what others think, and anyone else on the Zoom meeting. So the first step, it seems, in the United States would be to require EHR vendors who want to be part of the EHR certification program to offer shared access. Not everyone does. The 2 big vendors in the United States, Epic and Oracle, they do offer it, but then we know there are many smaller companies that may or may not offer it. So that would be sort of the first step. And currently it is not a requirement it is not a requirement out of our federal regulatory bodies. Then I'm not sure well, I'm curious to hear what my other colleagues think about requiring clinicians to offer it. That could also be a regulatory decision that you have to turn the function on. But the uptake, again, you know, requiring that it's turned on and actually encouraging adoption and uptake are 2 different, very different challenges.
So I'll just respond. Oh, Tim, I didn't mean to speak over you.
Oh, please go ahead, Jennifer. I'll go after you.
Yeah, I was just going to say that I think it's a very important question. One of the benefits of this approach is that it puts the uptake in the patient and family's hands, as opposed to imposing additional demands on busy clinicians and staff. You know, there's just tremendous burnout right now in care delivery. So I think making it available is important, making it easy and transparent, and streamlining that process is important. I also think that there's certain scenario. This is something that is really, we've been focusing here on age-friendly care. It's especially important to normalize advanced care planning and what matters and engaging family for older adults, but it's really relevant across the life course. And so I think that in terms of like thinking about key populations and making it like an always situation. For example, in dementia, someone gets a new dementia diagnosis. I think it would be entirely relevant to stipulate that shared portal access registration is just something that should always be done. or people with serious illness is sort of another situation. And you certainly could think about like both carrots and sticks, and so like quality measures where certain providers are doing this more often, potentially having some preferential treatment would be useful. I think one other important thing is that shared portal access, you can measure it very easily, and that's really important because it's something that is feasible to be able to monitor.
That's a great segue, and I see Lisa has her hand up too. I want to make sure we get to Lisa. Real quick, just to say that when Jennifer mentioned quality measures, makes me think of the CMS age-friendly hospital measure, which includes 5 domains, all focused on the age-friendly 4Ms. The first domain is eliciting patient healthcare goals. We now have tools like MyChart Bedside, where you can actually do messaging from the hospital room. And I think the next frontier is going to be the ability to sort of make this information available across care settings. And so even though there's not a requirement in that measure for shared access, which is largely residing on the outpatient side, I think as the age-friendly movement continues and the CMS comes out with more requirements, you're going to start to see shared access as a great way to meet that domain 1. So I think that's something health systems could definitely do.
Thanks, Tim. Thanks, Jennifer. Lisa, what's your question?
Sorry. Yeah, I just had a real quick question. My original question was around uptake by practitioners, and it looks like focusing on the patient perspective. Did you get any data or information around uptake by practitioners in terms of, just my personal experience working with my mother-in-law's provider? He doesn't think we need to worry about seeing her medical records. She, of course, agrees with him. But then my second kind of related question is, as you're looking at uptake by both patients and practitioners, have you looked at all at the pediatric populations? Because proxy by parents for peds, it's just, I think somebody mentioned, I think Jennifer, you mentioned something about care planning with older adults. It's just assumed when you walk in with a newborn that you will have proxy access. So I was just curious if you had looked at how they got people on board, if that was relevant to these older populations.
Ken, do you want to talk about the clinical perspective?
Yeah, I mean, certainly, no, I think we have a lot to learn from pediatrics. And actually, someone told me the other day that there's a baby-friendly movement that I need to learn more about. I don't know that there's been as much done looking at the kind of the clinician side of the coin. One comment that Rosie made to me yesterday about, and I don't want to speak for you, Rosie, but I learned from you that sometimes patients are interested in what matters to the care team. So it kind of works like the inverse way, and there can be a nice connection made there. But let me defer to Jennifer to answer the rest of that question.
Thanks, Tim. Yeah, so I guess I have 2 comments. The first was that this was an initiative where I think there was growing enthusiasm among our clinical partners, that we initially worked with sites that were receptive to the project, but I think at the end there was like greater commitment to the value of shared portal access. And on terms of the pediatric side, I don't have empirical data, but I know that one of my colleagues who was a physician resident at Hopkins, her mother had a stroke, and she one day was going around to various appointments with her mother and was asking about shared portal access, and none of the specialists were able to help her. They kept saying, well, why don't you just log in as your mother? And then finally, one of them said, well, I think they do this in pediatrics, and they actually called to pediatrics and were able to figure it out, but it was only, and I think it's just because they do it in pediatrics. It's actually a very simple process once you understand the workflows. Looks like Nina has her hand up.
Yes. Mina, do you have another question?
Yeah, one quick question. If I want to at least try it out in my setup, where should I begin? Who should I talk to?
I'll maybe take that one. I would say probably try to find out if you, I'm not sure what your system looks like, but if you have a health information, or I guess, medical records office, if you will, that might be a good place to start. I think also identifying an information technology professional who might be sort of managing Epic or whatever EHR. At least in larger health systems, there can often be several layers to this, not surprisingly, and committees that are involved with the governance of this. So we, for example, have a MyChart governance committee. So when we want to send out a blast message, say we want to send a message to every patient, every MyChart user during COVID about, make sure you consider getting vaccinated, that had to go through a governance committee. And so you may run into some of those types of things, but those folks can also be quite helpful in getting you started in your system.
Cait or Rosie, do you have anything else to add to that?
No, I've been seeing a question a couple times in the chat about different versions of Epic, and do different versions have different requirements? And I have 5 Epic accounts. They're all connected now, but they're not connected. I mean, I can access one and then I can go to the other one, but they don't share information a whole lot. But what they do, I mean, every version has its own different. And I remember, Cait, when I did this while we were having a meeting, and I went to each version of Epic, and every version of Epic had a different way, or every health organization had a different way of accessing the shared access, or the proxy at that point. And that was really, for me, was very hard to do, because it was like everybody had a different, sometimes we had to go in and sign up, and sometimes they had to be a member of that organization, otherwise they couldn't be a proxy for me, or it was a lot of different things. And so I'm on the patient advisory group or council for Epic for MyChart. And one of the things we talk about, we say all the time, it's one of the things they have to fix, the shared access, and also the sharing between healthcare professionals. So basically, both those things need to be fixed at this point.
And that's a really great point that Rosie is bringing up. If you talk to people at Epic, they will say, make it so easy. Just go over here, click the sharing hub, click the thing, send the email. And it actually can, I've had a personal experience where it really took about 30 seconds to sign up. But organizations, because primarily they're worried about inappropriate disclosure of information and risk management and compliance, will often put some of those things in place that Rosie's mentioning, like you need to sign this form, or you have to be a patient in our healthcare system in order to be designated as a proxy for someone else. So there's kind of multiple layers of barriers. One is just navigation on the portal, which is, despite what Epic says, you still do have to kind of tree through various menus to get to it. And then layered on top of that are the things that organizations put in place. And then layered on top of that are just basic like awareness and education related issues. And Jennifer, your story about different people saying, well, just log in under your mom's name, in our secret shopper exercise, we heard that a lot. And for practices that are primarily caring for adults, many clinicians don't really know that this option exists. So I don't think it's a matter of they don't want to use it, particularly clinicians who are caring primarily for older adults, but just that they may not even be aware that it's a possibility.
Okay, I'm sorry to come to the closing of this great call. Like we could go on for another hour for sure. But I want to, Matt, can you pull up the slides, please? So I know Cait or next slide. Cait or Jennifer, or Tim, do you want to talk about this slide here? And I'll post the.
Sure. So this is a screenshot from the Coalition for Care Partners. Jennifer and I co-founded this initiative a couple of years ago, focused on developing and spreading health information technologies that support care partners. All of the materials that we talked about today are available here. So if you want to go back to if you're on a PFAC and you want to go back to your health system with an example, you can find both the branded materials here and the kind of white label materials that can be branded for your organization. The QR code brings you right to the page. And if you want, next, I think we have one more slide. If you want to join our Shared Access Learning Collaborative, it is a lively group that sets its own priorities for the kinds of projects that we work on together. And we've done things like the secret shopper exercise. We've provided comments on the National Strategy for Caregiving, among other things. Our next meeting is April 29th. It is open to everyone. It's a come as you are sort of meeting. You can sign up at the website, or you can contact Deb Wackenheim, whose email is now in the chat. Also, it's on the website, and we'd be happy to have you join us.
Great. I'd like to join that collaborative, I think.
Feel free.
Okay, so I know that many of you are members of our free online learning community, the PFCC Connect, but if you're not a member yet, we encourage you to register so you can access this great information and resources about patient and family-centered care, post questions, learn from others, share ideas and resources, and continue the conversation, something like we had today. Next slide. So we do ask that you complete the survey as we use the results to give us ideas to improve our conversation and also determine future topics. You can use the link or the QR code to access it. The link has been posted in the chat. Well, no, it hasn't, because I did not do that yet. So let me do that right now. So as I said, your feedback is super important to us. So we love to get the evaluation survey completed. Okay, next slide. We'll finish up. We're 1 minute over. Our next informal conversation will be held in June 2025. Their date and the topic will be determined. Recording slides and chat will be from this conversation will be posted on PFCC Connect site. And then if you have any resources that is aligned with what we talked about today, please send it to us so we can share with others on PFCC Connect. And if you want to send those to me directly, you're more than welcome to do that. So thank you so much for everyone taking the time. And I think this was just a super inspirational, very informative webinar.